Hello, my name is Rita Deering. It is 11:06 p.m. and this is my novel intervention presentation for MPH 603, Applied Behavioral Science, taught by instructor Karen Tompkins, which is due on October 28th at or before 11:59 p.m. My intervention is designed to address heart disease. Coronary artery disease, or CAD, is caused by plaque buildup in the wall of the arteries. Plaque is made up of cholesterol. Plaque causes the insides of arteries to narrow over time. Coronary artery disease is the most common type of heart disease. Cardiovascular disease is listed as the underlying cause of death and accounts for nearly 836,546 deaths in the U.S. That's about 1 out of every 3 deaths. About 2,300 Americans die of cardiovascular disease every day. On average, that is 1 death every 38 seconds. Coronary heart disease is the leading cause of death in the U.S. It's 43.8% of deaths attributed to cardiovascular disease in the U.S., followed by stroke at 16.8%, heart failure at 9%, high blood pressure at 9.4%, and disease of the arteries at 3.1%, and other cardiovascular diseases at 17.9%. As you can see by the slide, there are many risk factors for heart disease. The risk factors for heart disease are high blood pressure, high cholesterol, smoking, diabetes, obesity, an unhealthy diet, physical inactivity, too much alcohol, and what is not listed here is just having a sedentary lifestyle. So people like IT clerks or data entry people or administrative assistants have a higher likelihood than people that have more active jobs. One of the previous heart disease interventions that I examined was a previous heart disease intervention done by the CDC in 2010. And is fitting because it was a past intervention that largely failed considering current statistics. The intervention included policy and environmental change, behavioral change, risk factor detection, emergency care and acute care management, rehabilitation and long-term care management, and end-of-life care. The weaknesses listed for the previous intervention were unfavorable social and environmental conditions, adverse behavioral patterns, major risk factors, first event sudden death, diseaseability, risk of recurrence, fatal CVD complications, and decompensation. The strengths of the previous intervention is assessment. Although important gaps persist, the accumulated knowledge provides a solid evidence base for public health decision-making. Policy development. A wealth of policies have been developed on the basis of the knowledge of heart disease. And lastly, assurance. Public health agencies can put current knowledge to work through a targeted plan of action. Previous intervention goals. The goals of the previous intervention were social and environmental conditions favorable to health, behavioral patterns that promote health, low population risk, few events and only rare deaths, full functional capacity and low risk of reoccurrence, and good quality of life all the way up until death. In 2010, when the intervention was devised, the CDC had great hope for improvement. The theoretical framework for the previous intervention, and this is what I gleaned from an action plan from the CDC, was present reality. It summarizes current knowledge of progressive development, a vision of the future, intervention approaches, Healthy People 2010 partnership goals, target population, taking action, strengthening capacity, evaluating impact, advancing policy, and engaging in regional and global partnerships. And now it's time to discuss my logic model for my intervention involving heart disease. The first thing we would do would be to establish risk factors and see if the participants in the intervention are having issues with weight loss, if they have an unhealthy diet, if they smoke, if they drink, if they have a sedentary lifestyle, if they don't exercise, or if it's a combination of those things. The next thing we would do would have a psychological evaluation where we see what their X factor is, what's causing them to partake in these behaviors. What sort of an environment do they have? Do they have standing support? The next step would be to offer counseling. And then we would slowly integrate changes. I think the greatest rate of success we would have is not to toss a billion changes at these people at once. It would be to slowly integrate changes. Like in case of an unhealthy diet, slowly possibly replace things in their diet, like say going from canola oil to olive oil, or using kale instead of lettuce, or soy products instead of regular cheese and milk. Just gradual step downs over time. And ideally it would be a 12-month period, and having check-ins every 3 weeks as far as diet and exercise people go. Now, as far as smoking and alcohol abuse, that's a bit more tricky of a subject because they're technically addictions at that point. In which case we would, in the case of smoking intervention, there would be constant counseling. There would be free access to non-smoking aids like gum or patches or prescriptions like Chantix. Where with drinking, it's also a bit more complicated, again, because it is an addiction. So there would be AA meetings, sponsors that are already set up to go and ready to work with these people, and also to have the AA materials provided at low or no cost. Now back to the logic model on the slideshow here, we would again offer a support system. And as far as the weight intervention goes, a check-in every 3 weeks. Smoking and drinking interventions would have a check-in every 2 weeks. And I would like to establish a buddy system to where there's always support with the smoking, or not with the smoking, with the with the unhealthy eating and the non-exercising. Because support fosters an environment of success. Okay, for translation and implementation considerations of my intervention, they would have to be slow and gradual changes over time. Periodic check-ins with physicians and healthcare professionals. Dietitians, personal trainers, consultants, sponsors, all provided free of charge. So it'd be either covered through insurance or fundraising or government grants. It would also be essential to get the community involved. And personal accountability. If you feel like you're accountable for your own success, then you're more than likely to push yourself, even if you don't have support. And with the weight loss and exercise groups, a Fitbit would be a Fitbit device would be provided free of cost, and the Fitbit would have alerts in it to let people know, hey, it's time to get up and exercise, and it would send, text reminders to their phones and emails to their doctors as far as when they're getting exercise and when they're not. It would all add to that personal accountability factor. So, in conclusion, all of these factors are essential for success in reducing or eliminating risk factors. Personal accountability, support, determining what your X factor is, getting the community engaged, and much needed resources free of charge. Those all go towards success. Well, this has been my novel intervention presentation. I hope you enjoyed it and that it was informative.